Yeah, got it. Start. Check. Good morning and welcome you all to Boscon 2021, which is both virtual and real with limited audience. First, we start off with a free paper, which starts from 8:30 to 10:30 a.m. The first paper is by Dr. Ishwar, which is a prospective study of functional outcome of surgical management of type 3 radial head fractures treated by radial head arthroplasty. The judges will be Dr. Ravish Ningegowda, Dr. Srinivasalu, Dr. Nachiketan, and Dr. Krishna Prasad.
Good morning, everyone. I'm myself Dr. Ishwar, and my guide is Dr. Avinash P. I have done a paper on prospective study and of assessment of functional outcome assessment of a surgical management in type 3 radial head fractures, which is treated by a surgical processes, that is a radial head arthroplasty. Now, radial head. Radial head plays an important role in stabilizing the elbow. It provides the forearm as well as elbow stability, and isolated radial head fractures may be associated with most of the instabilities in the elbow. So most common fractures around the elbow occurs in a population of 1 lakh, about 30 patients. In that, 1% of the long bone fractures and 20% of the proximal forearm fractures. Classification of the radial head done by Mason in 1954. Type 1 is a marginal fracture without any displacement, which can be treated conservatively. And type 2, which is a marginal sectoral fracture with displacement and rotational restriction of movements in the forearm. Type 3 is a commuter fracture with the entire radial head is unreconstructable. So here comes the controversy whether type 3 radial head fractures should be either fixed or replaced. So in unreconstructable radial head, like it's better to go ahead with metal prosthesis is my paper. And later on, Johnston in 1962 gave another 4th type of Mason's classification with radial head fracture with an elbow dislocation. Radial head arthroplasty. Like advantages of a radial head arthroplasty instead of going ahead with the surgical excision is it restores the height of the radius, so proximal migration in most of the surgical resection of radial head. So it is avoided and it restores the stability in the elbow and a pain-free range of motion. Principle is exciting a unreconstructable radial head, do a broaching and insert an implant. That is the principle of my study. So need for the study is radial head, since its significance is as a secondary stabilizer of the elbow and distal radial ulnar joint. This, due to a fracture in the radial head, the stability is usually lost. So to assess the time period when the patient gets a pain-free range of movements following the surgery of a metal prosthesis is my study. To here, usually generally 2 approaches, couplants and crutches, both the approaches were used in my study. And radial prostheses were used based on the excised radial head sizes, and time of recovery is also assessed in my study. Objectives. It is by analyzing the functional outcome of surgical management of a type 3 radial head treated with the radial head arthroplasty, and it was assessed by a Mayos elbow index score and visual analog score. Materials and methods. This included patients of only type 3 radial head fractures which presented to Sanjay Gandhi Institute in a course period of November 2018 to September 2020. This study included 30 patients with the inclusion criteria and exclusion criteria for the study. My inclusion criteria was patient aged more than 20 years and only type 3 radial head fractures, not type 2 or not type 4, and neglected radial head fractures not more than 2 weeks of old. Exclusion criteria. Patients with less than 20 years age and type 1, type 2 and type 4 were excluded. and an open wound when the radial head fractures are excluded, and other ligamentous injuries if it is associated with the radial head, which can be lateral collateral ligament injury or a SX low pressure injury or a coronoid fracture as well or a terrible tear, also excluded. Next, this is a general methodology of my study. First, the history, clinical examination, then the radiological X-ray was done. Then for immobilized, the slab was put. Then pre-op evaluation was done. Then routine blood investigations and the radiological fitnesses, everything taken. Then like if it is whether coming under my criteria, inclusion criteria, then consent for surgery was taken and surgery was done. The radial arthroplasty was proceeded. Then I followed up the patients at 6 weeks, 12 weeks, and 24 weeks of period. These are the blood routine investigations which was done to acquire the surgical fitness in my cases. Certain cases just to rule out any ligamentous injury so that it doesn't come into my study. MRI was also suggested in few cases. Surgical approaches, both the approaches as I told previously, couplants and couches, both were done in my study. At deep dissection, the forearm was fully pronated just to avoid the posterior interosseous nerve to move it away from the operative field. Here, all mixed cases, modular radial head prosthesis was only used, and the articular dish of the implant should approximately matched with the articular surface of the native radial head. Then canal reaming, broaching was done. Then assembled modular prosthesis was inserted. After checking the trial implants, and I was making sure that 2 mm distal to the tip of the coronoid was assured, and medial ulnar humeral space also should be parallel. Postoperatively, patient was advised to keep the limb elevator just to avoid postoperative edema, and finger movements and shoulder shoulder joint movements were advised, and section was removed after 2 days of the surgery, and wound was inspected on the POD3, and antibiotics and sutures were removed postoperatively at 12th day, and check X-ray was done at 4th week, and later patient was discharged with the arm pouch, and patient was not advised to have any heavy weight lifting or do any exercise for the operated upper limb. Follow-up after the surgery, patients were asked to review in the OPD at 6 weeks, 12 weeks, and 24 weeks. And it was assessed in each period of time. Then patient was advised to have a physiotherapy exercise, full range of movements of the elbow, and CPM was also advised. And then my myos elbows in the performance score was also addressed in these cases. This is the myos elbows performance score. Pain, which was graded into 4, then range of movements up to more than 100 degrees, till less than 50 degrees. Then stability of elbow was assessed. Then routine functioning like grooming the hair, feeding, then hygiene, putting on the shirts, shoes, everything was given a score. Then accessibility was done based on good, fair, and poor, and excellent results were given. Then my results was age incidence. Like I could found that most of 50% of the patients were between the age of 41 to 50 years of age, and sex incidence was 57%, mostly were males. Then mode of injury was mostly 66% was RTA than self-fall. Most of the cases are operated within a period of 7 days of admission. Then functional outcome at 6 weeks age, 6 weeks of time during the first X-ray was done post-operatively. 15 patients had fair results based on myos, and another 15 cases were having good results. And 12 weeks of follow-up, first 15 cases were having a fair result, then 5 cases were having good results, and 10 cases were showed excellent outcome in the 12th week only. And by following 24 weeks or 6 months, only 1 patient showed to have a fair Mayo score, and 4 patients were having good Mayo score, and 25 cases were showing an excellent full range of movements. Complications: 5 patients developed elbow stiffness, 1 patient developed posterior interosseous nerve injury, and 2 patients developed heterotrophic ossification. Case illustrations. These are the radial head fractures treated with radial head implants, post-operative radiograph. Full range of movements, assessment of pronation, supination. This was another case of 30-year-old female, had an RTA. This was her post-operative photos. This is the third case with a 50-year-old male having an RTA. This was his range of movements. Conclusion, I could conclude that the secondary cell, it is radial head processes after stabilizing. It provides as a secondary stabilizer to a valgus force, and radial head arthroplasty as a accepted treatment option for an unreconstructible radial head in type 3 radial fractures, especially in cases of ligamentous injury or bony injuries and failed internal fixation or radial head excision. And use of a radial head implant leads to a good functional outcome, even in a severely comminuted elbow. In modern, highly demanding era, technically superior method of radial head replacement in type 3 radial cases is definitely having an excellent outcome. This is my guide, Dr. Avinash, Professor of Orthopedics in Sanjay Gandhi. Thank you, sir.
So we will have a discussion. Now that we have all the judges on board, I'd like to introduce Dr. Vanmali, Dr. Ravesh Ningegowda, and Dr. Nachiketan. So they'll be the judges for this session. So we have a 2 minutes of discussion now.
Aishwa, good morning.
Yes, good morning, sir.
You are, how did you come to a conclusion of excellent
Sir,
scoring?
both the scorings, two scoring systems we have adopted, sir. One is based on Myos elbow performance score and visual analog score, sir. Visual analog score, initially it gave assessment of only pain. Then follow-up of performance of the radial head operated cases with the elbow performance and doing routine hygienic activities like combing hair and buttoning shirt. Those things were addressed based on Myos elbow performance scores.
Because your complication slide and your scores don't match. You had radial nerve injury.
Yes, sir.
And there was stiffness.
Yes, sir.
So at the end of 24 months, you told that 25 patients had excellent score.
Excellent scores.
So how did you correlate those two things?
Sir, even though elbow stiffness was there, terminal restriction of movements was only there, sir. So I have brought up it as a elbow stiffness only, sir. But performance wise, based on Myos elbow performance score, all 5 cases showed more than 90 scores, sir.
Because once the elbow is stiff, you
Yes, sir.
can't assess the valgus and varus score.
Yes, sir.
So how did you correlate those things?
Since terminal range of movements were restricted, I placed it under elbow stiffness, sir.
Okay, thank you.
Yes. Thanks. Thanks.
Ishwar, you had any cases of revision radial head prosthesis?
No, sir. In posterior interosseous nerve injury, in one case alone, we had to go ahead with exploration, sir. Apart from that, no other cases like implant loosening or proximal migration was not noted, sir.
So how long was your longest duration of follow-up?
Follow-up was 6 months, sir, 24 weeks of time.
Longest?
Longest is 1.5 years, sir. November 2018, one case was operated. That was the longest period.
Oh, thanks.
Yes. Good morning, sir.
Did the pin recover in both the cases? You showed
No,
two
sir.
cases.
Only one case I reported as pin injury, sir. Like that case also, it was not recovered, sir.
Not
Not
recovered.
recovered. That,
So what did you do next for that?
sir, we advised
Because
this. Sir,
again, the score will not be good in that particular case.
yes, sir. I have showed it as fair results, sir. That case alone.
Right.
Thanks.
Thank you, Ishwar, for the presentation. We are good on time. Next is a presentation by Dr. Appa Saheb, a prospective study of minimally invasive percutaneous plate osteosynthesis using LCP for surgical management of distal tibia fractures.
Good morning, sir. Myself, Dr. Appasab. Myself, Dr. Appasab, and today my presentation topic is the functional outcome of minimally invasive percutaneous plate osteosynthesis using LCP for surgical measurement of distal tibia fractures. And my guide is Dr. Avinash. Distal tibia fractures are constitute about 10% of all tibia fractures. These are routinely seen as a result of road traffic accidents and twisting injuries and fall from height. And management of distal tibia fractures is challenging because of wound infections, poor wound healing due to precarious blood supply, and which is subcutaneous in whole extent, and which has a minimal soft tissue cover. Due to subcutaneous extent of the distal tibia, the open fractures are more when compared to the other long bones. Hence, the management of these fractures are more complex because of the soft tissue injury and frequently associated with interrupted vascularity of the fracture. This can lead to infections, non-union, and delayed union. Hence, the minimally invasive percutaneous placed osteosynthesis technique, which aims to reduce the iatrogenic soft tissue injury, reduce the bone vascularity, and preserving the fracture hematoma. And the aim and objective of the study is to functional outcome, radiological union, and complication in the patients with distal tibia fractures, which is treated with the MIPO technique using distal tibia medial LCP. In our study, we included patients age age 18 to 60 years and closed fractures and open fractures type 1 and extra and intra-articular distal tibia fractures. And we excluded the patients with open fractures, there is type 2 and type 3, pathological fractures, and old ankle fractures. Which study was conducted between November 2018 to September 2020 with 25 patients were included, and the average age of the patient is 39.48 years, and male to female ratio is 15 to 10. And majority of the patients were male patients. The patients are presented to us with the most common is road traffic accident of 18 patients and self fall of 7 patients. And most of the patients were closed fractures, that is 19 patients were closed, and remaining 6 patients were open type 1 fractures. And out of 25 patients, 17 fractures were associated with fibula fracture. And after admission, we classified the fracture according to AO classification. And out of 25 patients, 6 fractures were with AO 43C1, that is simple articular and simple. Surgery was done, that is 2 to 3 centimeter incision was done over the medial aspect, and soft tissue dissection done, and using a long medial LCP, we slided just below the skin, and we reduced the fracture with indirect reduction, and the fracture is fixed to the bone with the indirect reduction and K wires, and definitive fixation with screws, and so confirmed under CM. The post-op protocol, that is ankle range of movements are started on first day. If swelling was there on the second day, we immobilized with slab and non-weight bearing for 6 to 8 weeks, and follow-up was done over 6 weeks and 3 months, and 3 months, 6 months, and 1 year. The results of timing of surgery is 6 to 8 days. The average duration of the surgery is 1 hour 21 minutes. Average hospital stay is 12 days. And average time of the union is 16 weeks. The assessment was done using American Orthopedic Foot and Ankle score at 3 months, 6 months, and 1 year. Our mean AFA score at 1 year is 85.64, which was an increasing trend. And in our study, out of 25 patients, the 5 patients shows excellent result, and 13 patients were good, and 6 patients were fair, and 1 patient has poor result. Which was the study result at the end of 1 year, which shows the similar results with the other studies which was done on the same period. Out of 25 patients, the 4 patients had complications like superficial wound infection on 2 patients and deep wound infection on 1, and one other one has post-traumatic arthritis. The superficial wound infection was treated with culture sensitive antibiotics and non-adhesive dressing, and one deep wound infection was treated with which was implant exposure was there, which was treated with the local flap coverage and antibiotics. And another patient had persistent ankle pain and diagnosed as a post-traumatic arthritis, which was treated with NSAIDs and physiotherapy. These are the illustrations. This is a 35-year male had alleged of RTA, which was distal tibia fracture, which was treated with mepoplating and fibula plating, and which was follow-up at 3 months and 6 months. Another illustration. The conclusion is the minimally invasive percutaneous placed osteosynthesis is a reliable method fixation not only extra-articular and intra-articular fractures. A MIPO technique is a distal tibia offers a biological advantage by preserving blood supply and decreases the chances of delayed and non-union. Patients treated by MIPO technique has a much lesser rate of deep infection and excellent radiological union. A MIPO technique helps in initiating early range of mobilization and reduce the risk of ankle stiffness. Thank you.
Complications you told about 3 cases.
4 cases.
Yeah, with regards to wound.
Yes, sir.
But usually the incision is an oblique incision. What you have shown is an linear incision there. The distal part of the tibia,
Yes, sir.
for a distal tibia LCP,
Yes.
usually it's an oblique incision what we put.
Yes, sir. The midline is 2 to 3 centimeter incision was the medial malleus just curved anteriorly.
The thing is, normally it is an oblique incision, distal tibia.
Which one is, sir? Curved anteriorly. It will be.
Your marking and incision shows it's a straight linear incision, what you have done there. What you have shown here.
Yes.
It will be a problem with the wound healing.
Now, out of 25 patients, only 2 patients had just a superficial wound infection like blebs, and that's it, sir. And which was treated is just dressing and antibiotics.
Normally an oblique incision usually is used.
Apasab,
Yes.
you told that, in your aim of your study was to assess the radiological union.
Yes, sir.
So how did you assess the radiological union?
Radiological union just by regular X-rays at regular follow-ups at 3 months, 6 months, and at 1 year.
Was there any criteria?
So what are the criteria you have considered to say that it is united radiologically?
And, we follow up the patient at 3 months, 6 months, according to AFS score, that is the pain-free, and
Radiological. Okay.
thanks.
Thank you, Apasab. Next is a presentation by Dr. Yoganand. Functional outcome of surgical management of ankle fractures with syndesmotic injury.
Presenters, please stick to the allotted time. So at the end of 6 minutes, your presentation will be turned off.
Morning, everyone. I'm myself, Dr. Yoganand, and my today's paper is on surgical management of ankle fractures with syndesmotic injury, which were assessed for which I have assessed the functional outcome. Ankle is a complex uniaxial hinge joint which consists of tibio-talar joint, the subtalar joint, and the inferior tibio-fibular joint. This syndesmotic ligament makes an important contribution to the stability of the ankle joint. This includes the anterior inferior tibio-fibular ligament, posterior inferior tibio-fibular ligament, transverse tibio-fibular ligament, and the interosseous ligament. So these syndesmotic injuries are a very severe form of ankle injuries and are important to detect because they may lend stability of the ankle joint. These syndesmotic injuries are very less common as compared to the ankle malleolar fractures, which constitutes only about 10% of all ankle fractures. These syndesmotic injuries are most commonly associated with pronation external rotation or pronation abduction, and less frequently with supination external rotation ankle type of ankle fractures. These ankle injuries are disastrous if not treated properly, especially in patients like athletes and those persons who are engaged in heavy work and persons who mainly walk on rough or irregular surfaces. So the objective of my study was to assess the functional outcome of surgically treated ankle fractures with syndesmotic injury using American Orthopedic Foot and Ankle Score. So it was a prospective study. It was a project study which was conducted between November 2018 to March 2020, in which the fracture was treated surgically with a fibular plate, syndesmotic screw fixation, and medial malleus fixation. The pronation external rotation type of injuries, supination external rotation type of injuries with confirmed syndesmotic injury intraoperatively by Cotton's test were included in the inclusion criteria. Then I have excluded ankle fractures which was associated with ipsilateral distal 1/3 tibia fractures, evidence of any already existing arthritis of the ankle joint, revision cases, and also open injury cases. 40 patients who have met this criteria and above 18 years and willing, I have included in the study. So coming to surgical technique, first the fixation of the lateral malleus was done using a standard posterolateral approach. After fixation of the lateral malleus, the syndesmotic integrity was assessed by using Cotton's test and a fluoroscopy, and the medial tibiotalar clear space and the tibiofibular clear space was assessed. The fibula was reduced into the incisura, and a 3.5 mm tricortical syndesmotic screw was put up approximately 1 to 2 cm above the plafond in a posterior at a 30-degree posterior lateral to anteromedial direction. And after fixation, the syndesmosis was again assessed using fluoroscopy. The medial malleus was fixed with cannulator canal screws or tension band wiring. In the post-operative period, parenteral antibiotics were given, and after 10 to 12 days, suture removal was done, and the ankle mobilization was started afterwards. Coming to follow-up at 1 month, 3 months, and 6 months were done. X-rays were taken to monitor the progress of fracture healing, to check the ankle motility and whether the implant is well placed or not. Then the patients were started with ankle mobilization after the surgery with assisted toe touch walking with a walking aid for 6 weeks, and then full weight bearing. The removal of the syndesmotic screw was done after at least a minimum of 4 to 8 weeks if the patients are symptomatic with persistent pain while walking. American Orthopedic Foot and Ankle Society score was done to assess the functional outcome at a 6-month follow-up. These were my results. In my study, the ages between 31 to 40 were high, and there was male preponderance. The mechanism of injury, most commonly it was more pronation external type, followed by supination external type of injury. At 6-month follow-up, the AFR score was like this. I had excellent result in about 17 cases, constituting about 43%. Good result in about 18 cases, which was about 45%. Fair outcome in 3 cases and a poor outcome in 2 cases. Ankle with non-anatomically reduced syndesmosis may progress to osteoarthritis and cause lifelong disability. So the primary goal of treatment in these cases should be obtaining a stable, pain-free ankle joint and to restore the maximum function. In our study, the syndesmosis was fixed with the tricortical screw fixation using a 3.5 mm screw, because there was no difference in outcome which was reported previously with the use of cortical trelateral fixation in the literature. In our study, we had 7 patients who complained of pain while walking, for which syndesmotic screw removal was done. So in our study, coming to complications, 2 patients developed the superficial wound infection, which subsided with regular dressing and antibiotics. Of the 2 patients who reported poor outcome, both had ankle stiffness. The mean AOFA score in our study was 87, which was in contrast to the study by Igor et al., who demonstrated a poor outcome after 1 year of follow-up with syndesmotic injury. However, many studies indicate that anatomical reduction is the most important factor which affects the functional outcome in ankle fractures. The limitations in our study being the small study group and a shorter follow-up time. These were some of my follow-ups. This is pre-op, immediate post-op, and also at 6-month follow-up. This was the second follow-up. This was my third follow-up. This was my fourth follow-up, for which the patient was symptomatic and the syndesmotic screw removal was done at 10 weeks. Coming to conclusion, the treatment of ankle fractures with syndesmotic injury with open reduction and syndesmotic screw fixation gives good results, provided a good anatomical reduction is achieved. Literature says there is no difference between tricortical versus quadrilateral fixation, but in our study, we have achieved a good result with tricortical syndesmotic screw fixation. Thank you, sir. Sorry, sir.
Along with this
No, sir. Only syndosmitic. No ligament.
Only bony.
Yes, sir.
Any MRIs were done before?
No, sir. It was intraoperative. We have assessed. Then only we have taken into inclusion criteria.
So only in few cases you removed the screw in about 6 to 8 weeks.
Yes, sir.
The rest of them continued to have.
Yes, the rest of them continued because they didn't have any symptomatic when we are following it up. So we continued the same. Sir.
So when did you allow them to weight bear?
Sir, at up to 6 weeks, toe touch weight bearing. Sir, post surgical after suture removal, we have started passive mobilization with the toe touch weight bearing with walkers. After 6 weeks, full weight bearings.
Any cases of screw breakage?
We never follow up. I didn't get any, sir. Thank you, sir.
Thank you, Yoganand. Next presenter is Dr. Anil Kumar. Sham, yeah. So we had a little bit of technical difficulty. It's sorted now. So next presenter is Sham Sundar, Dr. Sham Sundar, prospective study of functional outcome of thoracolumbar port spine with posterior only approach.
Good morning, sir. Good morning, sir. Myself, Dr. Sham Sundar. I'm presenting a prospective study of functional outcome in thoracolumbar port spine with posterior only approach, that is posterior decompression, debridement, and stabilization. Since spine is the most common site for osseous involvement of tuberculosis, accounting for around 50% of musculoskeletal tuberculosis cases. And among the spine, thoracic spine constitutes the most common. And surgery is indicated in patients having disabling back pain or progressive neurological deficit despite conservative management. And regarding the approach for surgical decompression, debridement, and stabilization, we have anterior approach, combined anterior and posterior, Traditionally, the anterior approach is gold standard since the pathology is mainly anterior involved. So debridement is possible. And recently, the posterior approach has gained popularity based on the principle of adequate decompression, debridement, and stable fixation with much lower complication rates. And it also provides three column fixation via pedicle screws by the same approach. And the objective of our study is to study the functional outcome with posterior only approach in thoracolumbar tuberculosis with respect to postoperative neurological improvement assessed by Frankel's grading, and postoperative deformity correction and fusion, postoperative AS scores and ODS scores, which are the functional scores and complications of the procedure. And the inclusion criteria of this study are patients more than 18 years and above with informed consent, patients with progressive pain and neurological deficits not responding to 6 weeks of chemotherapy, and development of neurological complication during the course of chemotherapy. And significant vertebral body destruction or collapse we have taken is less than 60 degree, and exclusion criteria more than 3-level involvement, kyphotic angle more than 60 degree, patients with kyphosis due to old age lesion and skip lesions and miliary TB, and those who are not willing for surgery. 20 patients with thoracolumbar port spine who fulfilled the inclusion criteria were selected for the study and treated by posterior decompression and stabilization. No patients were lost to follow-up, and results were analyzed in terms of neurological assessment done by, as said, Frankel's grading, fusion assessment by visual criteria, and functional assessment is pain by visual analysis score and ODS index. These intraoperatively, preoperatively after taking a plain radiograph and MRI, confirmation of the diagnosis on suspicion basic on the MRI, proceeding with the case, placing the patient prone on a spinal table, we approached a midline incision. Before decompression, under the CM guidance, introduction of the pedicle screws, followed by the transpedicular decompression. We can see the caseous pus, followed by maintaining the stability by kyphotic correction. And this is the immediate post-op and a 3 months follow-up X-ray of the same patient. And post-operatively, we have continued the anti-tubercular regimen according to 9 to 12 months course. And we monitored regular ESR, CRP, and X-rays to continue the anti-tubercular course. And coming to the results, most of our patients or more than 30 years of age, and among them 31 to 40%, 31 to 40% of the patients between the 31 to 40 years, and among the 20 patients, we have majority of the patients are 60 patients in our study. And distribution of level among our patients, D12, D10, L4 and L5, and D10 and D11 constitute 20%, 40% among our 20 patients. This is the visual analog score, which was mean visual analog score at the pre-op was 8.45. Immediately after the post-op, it has decreased to 2.95. And by the end of final follow-up, the patients were pain-free. Most of our patients were pain-free. This is the Oswest's Disability Index, which is used to assess the functional assessment, which includes sitting, standing, walking, pain-free movements, sexual. This is one of our case, 26-year-old male patient with involvement of T12 and L1. That was this is the immediate post-op X-ray. This is a 6 months post-op X-ray. At the end of final follow-up, we had noticed the screw breakage at the end of final follow-up, but the time the patient had bony consolidation and no patient was asymptomatic, and we had advised for no active intervention. And this is one more case, 45-year-old male patient with involvement of D9 and D10 level with Frankel's grade C. This is the immediate post-op X-ray, and this is a 6 months follow-up. In our study, the level of involvement, that is D10 and D11, as said earlier, and L4 and L5 constitutes more common. And as in the case series followed by Turgot, it was reported that thoracic segment of the spine was predominantly involved in the study group. And the Park et al. Yes, reported a predominant involvement of lumbar segment vertebrae contributing to 44.8%, followed by thoracic vertebrae and thoracolumbar hinge. 85% of our patients had showed signs of neurological recovery. Among them, only 3 patients were in grade E, and only 1 patient had no neurological improvement. There was no further 17 patients has the definite fusion of grade 1, and 2 patients had probable fusion. Analyzing these rates with the posterior only surgeries as done by Guen et al. And Sao, Guen has shown 100% fusion rates in his surgery. Sao had reported 55% of 18 cases, and Lee has no fusion reported. There was significant difference in the mean VAS scores with a statistical significant at p-value of 0.5, which was comparable to Sao et al., Guen et al. And the majority of the patients were pain-free at the final follow-up. In a study by, and the ODI scores were comparable to the Zeng et al. Study, which we has conducted only, who has worked, operated on only thoracolumbar single level involvement. Coming to the conclusion, a posterior approach preferred because of its familiarity and simplicity and its low complication rate, and because of the decreased operative time, decreased blood loss. And the posterior approach, it gives a reasonable access to lateral and anterior aspects of the cord for an equal good decompression of the cord. You can approach based upon, you can do unilateral, bilateral laminectomy, and you can decompress the cord in old age people. It is an additional advantage, the canal stenosis. It is a less morbid approach and avoids problems associated with thoracotomy and laparotomy, which is more with anterior approach. It facilitates early mobilization and avoids problems of prolonged recumbency, and it provides better functional outcome and significant better sagittal plane and kyphotic correction. A kyphotic correction loss was 2 standard deviation. Just seen.
Sham,
Sir.
What was your ATT protocol? You started them on preoperative.
Yes, sir. Preoperative will be even after diagnosis of paradiscal involvement of a TB. We start with anti-TB therapy. If the patient has no neurological deficit, if he's just having disabling pain, we'll continue the course. If a patient is not responding to the AKT, we'll proceed. We have taken him for surgery, sir. And immediately after surgery, we resume the course of AKT as per the continuation phase and intensive phase. And based upon the ESR, CRP levels, and based on the X-ray bony consolidation, we have continued the course. Most of the patients, we have continued the course till 1 year.
What is your absolute contraindication for posterior approach?
Sir, absolute contraindication is more than 3-level involvement and more kyphotic angle more than 60 degree, where we can't correct the kyphosis posteriorly. We have to go anteriorly, address the spine, anterior instrumentation and posterior instrumentation is required, sir.
How was it assessed preoperatively?
Sir, Cobb's angle we have taken.
Any CT guided biopsy before starting?
No, sir. We haven't taken any CT guided
No,
biopsy.
now the government protocols have changed. You cannot
Yes, yes,
start
sir.
an ATT without
CT
an diagnosis
Yes.
because it's an illegal now. Last 1.5 years, you can't do that. Earlier, we used to start with an empirical treatment. Okay, how many days you should treat ATT before taking it for surgery?
Sir, 2 weeks, at least 2 weeks we will take, sir.
2 weeks. No, when did you plan you can do an immediate surgery in certain cases?
Sir, when the patient has presented to you with neurological deficits, we have operated the cases, sir. But if a patient had no neurological,
I'm asking about your cases, the timing of surgery.
sir,
Because all cases can't be the same.
sir, everything was elective, sir. Elective surgery, sir.
Request the presenters to please maintain the timing. Next is by Dr. Arjun Kumar, functional outcome of anterior cervical discectomy and fusion with anterior cervical plate in cervical disc disease, a prospective study.
Good morning, everyone. Yeah, this is my paper. My paper is functional outcome of anterior cervical discectomy and fusion in cases of cervical disc degeneration. And my presenter myself, Dr. Arjun Kumar, and my guide, Mohan sir, from Department of Spine Surgery, Sanjay Gandhi Institute of Trauma and Orthopedics. Coming to introduction, anterior cervical discectomy and fusion was first described by Clavard, Smith, and Robinson in the year 1958, and shortly later by Ursh in 1960, who described that anterior cervical discectomy and decompression should be done, and the debate for the interbody fusion. The indications for ACDF is radiculopathy, myelopathy, myeloradiculopathy, and traumatic instability of the cervical spine involving single or multiple levels. In ACDF, the anterior cervical cord can be decompressed and also preserves the stability of the spinal column. Patient with cervical radicular syndrome due to disc herniation who are refractory to conservative management are offered ACDF as a standard procedure, often in combination with interbody fusion or not. Although the disc arthroplasty and disc replacements are gaining popularity, still ACDF still remains the gold standard procedure. The aims of the study was to analyze the clinical outcome of anterior cervical discectomy and fusion with an anterior cervical locking plate in cases of cervical disc herniation, and to assess the change in quality of life after ACDF with anterior cervical locking plate. The methods and materials, all the patients with cervical disc degeneration with radiculopathy and neurological deficits who underwent ACDF with anterior cervical plate in our institute during the duration of 2018 of June and to May 2020. The inclusion criteria was 30 to 65 years of patients who were not responding for conservative management for more than 6 weeks, patient with acute neurological onset of deficits or severe radiculopathy, patient in which selected cases wherein the cervical spinal canal stenosis was there and could be adequately decompressed. And most of all, the informed written consent regarding complication also to be informed. The exclusion criteria was previous cervical surgeries, multiple disc herniation, infection, bone neoplasm, pathological fractures or immunocompromised patient, spinal anomalies, stroke or parenchymal deficits, any stroke or psychiatric disorder, any serious comorbid conditions in which surgery is more difficult, sir. We had 50 patients who met the criteria who were above 18 years and were willing to participate and gave informed written consent. Anterior cervical discectomy and fusion with anterior cervical plate was done with Southwick and Robinson approach and was carried out. Following the patients' visits were done in 6 weeks, 12 weeks, 6 months, and 9 months, sir. And during this follow-up, presenting complaints, the general examination, local examination, as well as the standard radiographs were recorded. A functional outcome of scorings was done by SF36 scores, neck disability index scores, and VAS analog scores, sir. My results, sir. In the whole our study, we found that majority of the patients, 38%, followed by we could see that maximum level of disc degeneration was in the C5, C6, sir, which was about 58%. There we encountered two levels of two disc disease, which was C4, C5, C6, which was about 8%, sir, and C5, C6, C7, which was about again 8%, sir. Coming to the neck disability index scoring system, I have plotted the graph in which the preoperative was 29.84, which was gradually improved to the final follow-up of 7.22. With this Friedman test was used to compare the neck disability scoring system scores, and we could see that it was statistically significant, sir. Again, with visual analog score, it started off in 8.56 preoperatively mean value, and which was at the end of the 9 months, it was 1.86. With again Friedman test at different intervals of time, we found that the study was significant, sir. Similarly, with SF36 scoring system, the preoperatively it was 33.71, and it had an increasing and gradual trend of up to mean value of 47.38 at the end of final follow-up, sir. And using ANOVA t-test, we found that it's also statistically significant. Now, coming to the complications, the adjacent disc disease was approximately 6%. The CSF leak was in 2%, sir. Dysphagia was in 2%. Transient recurrent laryngeal nerves and osseous was in 4%. UTI was in 2%, and wound infection was about 4%, sir. Now, discussion. The demographic variables of our series was very much comparable to Ali et al., where male patients were predominant, and C5, C6 was the most common site of disc herniation, sir. The level of significant improvement was in neck pain, arm pain, and visual analog score as compared to Wang et al. Fraser et al. In the study noted that the fusion rates were maximum in the group with plating. The overall fusion rate was 84.9% with only anterior cervical discectomy without fusion, 92% in cases where fusion was performed, and 97.1% where fusion with plating was done, sir. Similarly, in Mobs et al. Did a study wherein he found that higher fusion rate was done with plating group, which was about 99%, and only a fusion group, which was 93%. In the study with Lee et al. Found that the neck disability index, visual analog score, and SF36 improved of the patient from 17 with a standard deviation of 2.9, 6.1 with standard deviation 1.6, to 29.1 with standard deviation of 7.1, to 10.5, 1.8, and 50.6 respectively in a 2-year follow-up period. Similarly, in our study, we found that the values were similar, and the preoperative values of a neck disability index was 89.84, 8.5. Yes, this is my case discussion, sir. I'll just quickly run through it. This is my preoperative X-ray with flexion and extension views. Preoperative MRI showing C5, C6 disc herniation, and I could see positioning of the patient. We could fluoroscopic guidance for the exact site, and autologous bone graft was taken. Adequate decompression was done. Plating was done. Following which, this is my final follow-up of the patient, sir. My conclusion is 1 or 2 levels of anterior cervical discectomy and fusion with anterior cervical plating in cervical spondylolytic radiculopathy and myelopathy is a safe and effective procedure, which provides excellent early return with a minimal complication rate. Cervical plating also increases the risk of fusion and reduces the graft-related complication. This study shows that there's clinical improvement in the patient overall and low complication rate associated with anterior cervical plating, and just justifies the use of anterior cervical plating in cervical degeneration. Thank you, sir.
How many days did you follow up?
Sir, total 9 months follow-up.
9 months, because you showed adjacent
This
disc degeneration.
Yes, sir. Usually
No.
9 months to 1 year it will.
But what we have seen, it's usually a long follow-up.
Yes, sir.
It doesn't occur so early. Have you missed out any disc there earlier in the first MRI before the start of the surgery?
Sir, we operated only on those discs which was symptomatic, and dermatomal pain was there and radicular pain, sir. There may be disc degeneration which was not
because very early in a 6 months or 9 months follow-up to get adjacent disc degeneration, it's very, very early.
Yes, sir.
It usually a long-term follow-up. It is a recent concept. From past 5-6 years, this has come into the fore.
Yes, sir.
Earlier, this was not there.
Yes, sir.
So when you are terming a complication, you should be very careful.
Okay.
You put on so many references that compared your paper. So anything other than mentioned in those papers, have you compared, or have you found anything new in your paper,
Sir,
other than bony union or secondary degeneration? So which was specific to your paper or your study?
my paper was only about clinical improvement and functional improvement of the patient, sir. And with regard to that, whatever article I could get, I've compared, sir.
No, what about, you told it is 82.7% or something.
Yes, sir.
What about the rest, that remaining 17%? What had happened for the fusion?
Sir, in our study, sir.
Your study you compared, Allah.
Sir.
Fusion rate was less. So what happened to those patients? That 17% where you did not have fusion.
Delayed fusion, sir, or pseudo arthrosis is possible, sir.
So that will be a problem. Once again, they'll come back to you.
Yes, sir.
So anything was done for those?
Sir, at the 9-month follow-up, none of the patients had such issues that had to be intervened, sir.
But your fusion rate, what you have shown is less. That's why I'm asking. It's your result.
Thank you, sir.
Thank you, Arjun. Next will be by presentation by Dr. Sindhu. Clinical outcome of short PFN versus long PFN in management of stable intertrochanteric fractures.
Good morning, everyone. The study is mainly a comparative study regarding the clinical and functional outcome of stable intertrochanteric femur fractures treated with long and short PFN. Presenter myself, Dr. Sindhu, and my guide is Dr. Prakashapati H. Intertrochanteric fractures are one of the most commonest injuries which we encounter during the orthopedic practice. And the incidence is mainly about 50% of all the proximal femoral fractures. And coming to the incidence according to the gender wise, it is about 63 and 34 per 1 lakh population in elderly females and males respectively. And more common in females likely due to the postmenopausal metabolic changes. Our aim was mainly to compare the clinical outcome of short PFN and long PFN, which was used in management of stable intertrochanteric femur fractures. And we had considered 40 cases of stable IT femur fractures, which presented to the casualty, which were randomly divided into 2 groups with 20-20 each. 20 patients were treated with short proximal femoral nail and 20 patients were treated with long nails. And the study period was between December 2018 to September 2019. So we included the adult patients. The age criteria was between 18 to 80 years. All the patients were included between 18 to 80 years and stable IT femur fractures and patient who gave consent for surgeries. We excluded all the open fractures and ipsilateral distal femur fractures or proximal tibia fractures, all the pathological fractures, patient who are not fit for surgery, who are not willing for surgery, and neglected cases. So methodology was when the patient presented initially, all the resuscitative methods were considered and associated injuries were managed. Radiological evaluation was done thoroughly and the fracture pattern was classified. Stability was considered mainly on the integrity of the posterior medial cortex. So unstable patterns were considered as posterior medial fragmentation, basicervical patterns, reverse obliquity type of fractures, and displaced or comminuted lateral wall fractures. And when the fractures were not able to reduce after internal fixation, like after close reduction. And all the other routine investigations were also performed, routine blood investigations and X-rays. So the surgical technique was patient was put on a traction table, supine position, incision was given. Then the entry was taken at the tip of GT or just medial to the tip of the greater trochanter. Guide wire was passed. Then randomly it was divided into 2 groups and based on that short and long proximal femoral nail was used in the management. So post-operatively limb elevation was given and antibiotics was given for first 3 days. If required, blood transfusion was given. According to the physiotherapy protocol, static quadriceps was started on first post-operative day and on third post-operative day, quadriceps and hip flexion was initiated. So dressing was done accordingly. Sutures were removed on 12th post-operative day. And as soon as possible, when the patient was tolerable, he was advised partial weight bearing and total weight bearing was considered after radiological union. Coming to the results, among the 40 cases, the average age group was 55 years in case of short PFN group and 56 years in case of long PFN group. And male predominance was there in a short PFN group, while equal population in long PFN group. So mechanism of injury in both the groups was mainly due to slip and fall. Operative time, considering the operative time, it was long in case of long PFN group, which was about mean of 55.15 minutes. And in short PFN group, it was about 50 minutes. Considerably, the blood loss was also more in case of long PFN group, but it was not statistically significant. And time for union in case of long PFN group was around 16 weeks. And in short PFN group, it was around 14 weeks. According to modified Harris HIP score, which was used to evaluate the functional outcome at the end of 1 year, among the long PFN group, it showed a slightly better modified Harris HIP score, which was 89.75. And in case of short PFN group, it was around 85. So our results in case of short and long PFN group, if we look into detail of modified Harris HIP score, both the cases had a pretty good amount of excellent results, which was 8 patients, and good results, which was about 9 patients. And a poor result was seen in 1 patient of short PFN group in case of implant failure, while in long PFN group, we didn't have any poor result. So these are the complications to consider: anterior thigh pain in 1 patient of short group, implant failure in 1 patient, persistent hip pain in 1 patient, and superficial infection in 1 patient. While in long PFN group, we had only persistent hip pain and superficial infection. So coming to the discussion, according to our study, we came into the following, we noted the following points: that short PFN took a lower operative time and lesser intraoperative blood loss, though it was not statistically significant. And post-operative incidence of anterior thigh pain was found in short PFN group, while it was not found in long PFN group. In terms of Harris HIP score at the end of 1 year also, we noted a statistically significant outcome, which was better in long PFN group compared to short group. And peri-implant failure was seen among 1 patient of short PFN group, while long PFN group didn't have any such complications. At the end of the study, we came to a conclusion that the functional outcome of both long and short PFN group are comparable, but compared to the modified Harris HIP score at 1 year of follow-up, long PFN had a statistically significant better outcome. So we recommended that long PFN is an effective treatment modality for stable intertrochanteric femur fracture, and it provides excellent stability, functional outcome, so that the patient can be ambulated as soon as possible. And it reduced the incidence of anterior thigh pain, which was found in short PFN group. These are the follow-up cases. This is a preoperative radiograph of a case with a stable intertrochanteric femur fracture, immediate post-operative X-ray. This is a 3 months and 6 months follow-up, functional outcome at the end of 1 year follow-up. This is another case which a 50-year-old male treated with short PFN, stable IT femur fracture, 6 months follow-up. This is the clinical outcome. This was a case which was treated with long PFN, again a stable intertrochanteric femur fracture. This is 3 months follow-up and 6 months follow-up. The patient had a good functional range of movement at the end of 1 year. Thank you.
Why was the choice of selecting an intramedullary device for a stable fracture?
So we wanted to compare the outcome of intramedullary device in both the long and short group in case of stable intertrochanteric femur fracture.
And none of your presentation slides show that there was a lateral view done, because how would you decide the stability only based on an AP view?
Intraoperatively, we took the CM image also, sir. For
But
the
before
AP
that,
view
you
as
would
well.
have
Lateral view.
randomized based on the X-ray.
We had done, sir.
So
Lateral
there
view,
is-
AP view, both we had done, sir.
So the randomization is biased because you have done only an AP view and
Randomly,
randomized
we
it.
categorized into 2 groups. Treated on.
What Vanmal is saying is you should have done a lateral view before deciding the implant.
Yes, sir.
And stable fractures, I think, why did you use a long PFN? And you have concluded that a long PFN is better than a short PFN for a stable trochanteric fracture.
Studies have shown that the incidence of anterior thigh pain is more in short PFN groups, sir. So while putting an intramedullary implant, they have concluded that it is better to use a long PFN so that you can prevent the anterior thigh pain incidence as well as the peri-implant failure or complications also we can prevent.
Still, DHS is a very good format for an stable trochanteric fractures. Well accepted still.
Random, hello. You randomly allocated the group patients, no?
Yes, sir.
So did you consider taking a lateral view, considering the bowing of the femur
Yes, sir. Full length femur AP and lateral view
in
is
all the
taken.
cases?
Yes, sir.
Thank you, Dr. Sindhu. Next is a presentation by Dr. Anil Kumar, a prospective study of functional outcome of comminuted metaphyseal fractures of distal femur using lateral locking compression plate and medial augmentation.
Good morning. Myself, Dr. Anil. My topic for the day is functional outcome of comminuted metaphyseal femur fracture treated with distal femur LCP and medial augmentation with TENS, and under the guidance of Dr. Chandrasekhar. Coming to the introduction, distal femur fractures are complex fractures. They produces long-term disabilities and produces a considerable challenge for the management. It constitutes about 4 to 7% of all femur fractures. They are most commonly seen in two groups, that is in elderly patients associated with high energy trauma and elderly patients associated with low energy injuries. Why it is difficult for treating distal femur fractures? Because these producers, because of their anatomy and the distal femoral condyles have thin cortices, they have wide medullary canal, they have relative osteopenia and short condylar fragments and comminution. This poses a problem for treating surgeons. In case of comminuted metaphyseal femur fracture, the stability is a major factor. Whenever there is a single column fixation, it lacks in medial wall support, which requires additional medial wall support with medial augmentation. These are the various classifications, knees and associate classifications. Though various classifications have been encountered, we follow AO classifications for both planning and management. The objective of study was to assess the clinical outcome and radiological outcome. In clinical outcome, we assessed knee range of movements, pain relief, return to his work and walking capacity, and radiological union and rehabilitation and surgical complications. Coming to materials and methods, the study was a prospective study design, which was studied between November 2018 to April 2020. It was conducted in our institute, Sanjay Gandhi Institute of Trauma and Orthopedics. We included about 20 patients. It was based on our hospital statistics who were filling both inclusion and exclusion criteria. We included the patients who was aged more than 18 years, and we included only all closed fractures and excluded patients less than 18 years and open fractures and those with associated with pathological fractures and polio affected limbs and the concomitant fractures in the same limb. These are the various surgical approaches. We followed a standard lateral open approach on the lateral side, and medial side we use a mini medial incision of about 2 centimeters. These are the various surgical steps. We approach the distal femur with the standard lateral approach. After incising the skin, after splitting the tensor fascial lata, exposing the fracture site, fracture was reduced and fixed with the distal femur LCP, and the principles of LCPs were followed. 3 times the length of the plate were used, and about 40 to 50% of the screws were fixed. In case of distal femur fractures, the components like alignment, restoration of the length were addressed properly. The picture saying the same. The last picture is depicting the medial incision. It was made about 2 centimeters above the articular surface. It was about 2 centimeters centered over the medial condyle. These are the CM pictures showing the alignments and placement positions and entry point for the TENS site. The patients were followed up every fourth weekly, initial up to 3 months. Then they were followed every monthly for up to 9 months and at 1 year. And patients were evaluated based on needs scoring systems, which included both functional and anatomical score. The functional score was given up to 70 score and anatomical score of 30. The functional score included knee range of movements, pain, return to work, walking capacity, and the anatomical score, both radiological and anatomical malalignments. The score was given excellent more than 85 and good between 70 to 85 and fair between 55 to 69 and poor with less than 55 points. Coming to observation and results in my study, the demography of my study was, it consists of 20 patients with 14 males and 6 females. The mean age of the patients were about 45 years and the average age ranging between 20 to 80 years. The mechanism of injury was road traffic accident and right-sided femurs were more involved. Coming to subtypes in the classification, we had 15 A3 type and 5 with C2 type of patients. All patients were approached with the standard lateral approach and medial side with mini incision of 2 centimeters for TENS incision. The surgical time was about 120 minutes and the radiological union was about 18 weeks and the average duration of weight bearing was 20 weeks and the knee range of flexion was on an average of 110 degree. The radiological union and other results were comparable with other studies, both dual plating groups and single plating groups. We had about 9 patients of complications, with 3 patients had a chronic knee pain on the medial side due to the chronic irritation of the TENS. And we had some 3 patients of superficial infections at the TENS side and both sides. And 3 patients had knee stiffness, out of which 1 patient also had shortening. The knee scores, we had about 45% of excellent results and 40% of good results, a total of good to excellent of 85%. And they had about fair results in 10% and we had 1 patient had poor results. This is an illustration of the cases. This was a post-op X-rays at 5 months and after 6 months, due to we had a chronic irritation on the medial side, we removed the TENS at the side and he had a good range of movements. And we concluded that for comminuted metaphyseal distal femur fractures, we require a dual column fixation. As in case of dual plating group, there is a more chance of stripping of periosteum both sides, which leads to non-union and other related complications. But in our study, we had a comparable results with dual plating group with early range of movements, stable internal fixations, and it doesn't allow any varus collapse or malunion and non-union. And the articular congruity was good even after follow-up at 6, 9 and 1 year. Thank you, sir.
So what was the size of the TENS nail which was used?
Sir, actually,
it was uniform in all the cases, or you changed the size?
We measured the narrowest diameter of the femur, sir. We followed about 30 to 40% of the diameter, and we calculated according to the diameter, and we used the almost like 2.5 to 3.5 millimeter TENS were used, sir.
See, the whole idea of plating medially is to give a
additional medial support, sir.
Stability.
Yes, sir.
Using a TENS, is TENS used for stable fixation or it's just an internal splinting?
It was like an internal splinting, sir.
So where is the principle followed of medial stability? It has just splinted internally.
Yes, sir.
So how did it achieve stability there?
3-point fixation.
3-point in the distal femur?
No, sir. Like actually for the TENS.
You told what type of plates do you use?
So distal femur.
No, because conclusion you were commenting on the plating, dual plating. Did you use a plate?
No, sir. It was a comparing.
TENS nail.
Yes, sir.
What was
comparing with the dual plating group, sir.
Okay.
When we compared with the dual plating group with medial locking plates.
And what were the plates used?
Both they have used medial locking plates and T-buttress plates on the medial side, sir. They had almost we had a similar lizard, sir, but they had a non-union and varus collapse and malunion with associated with both, sir. But we had similar results when compared to both, sir.
But it will be more common in a TENS rather than your plating,
sir.
The varus collapse or deformities, or it is more common in a TENS nail rather than your plating.
Yes, sir. But Thank you, sir.
Thank you, Anil. Next is a presentation by Dr. Vijay Vittal, a prospective comparative study of clinical and radiological outcome of open versus minimally invasive transforaminal lumbar interbody fusion in degenerative lumbar spine disease.
Kindly stick to your time.
Good morning, sir. Myself, Dr. Vijay Vittal Mundawadi. Today's topic is prospective comparative study of clinical and radiological outcome of open versus minimal invasive transfemoral lumbar interbody fusion in degenerative lumbar spine disease. My guide is Dr. Mohan, sir, from Department of Spine Surgery, Sanjay Gandhi Institute of Trauma and Orthopedics. Various lumbar fusion procedures are done for pathological spinal disease like spinal canal stenosis, lumbar spinal deformity and instability. The major goal in these surgeries are good fusion, stable orthodontic spinal segment and good disc height and vertebral alignment. Transfemoral lumbar interbody fusion is a proven safe technique for lumbar fusion, but it is associated with significant morbidities due to muscle stripping and retraction. Due to advent of improvement in imaging techniques, minimally invasive transforaminal lumbar interbody fusion got popularized due to minimized tissue trauma, less potential blood loss, and shorter hospitalization with reduced clinical symptoms and early mobilization. Minimal invasive TLIF had a higher radiation exposure and a longer duration of surgery. Coming to objectives of our study, was clinical and radiological outcome of degenerative lumbar spine disease treated with comparison between open and minimal invasive TLIF. Clinical comparison was done using a VAS score and ODI score, radiologically by Cobb's angle and Bridwell fusion index. Intraoperative blood loss, operative time, and length of hospital stay was also measured. Patients with grade 3 spinal canal stenosis, that is spinal canal diameter less than 9 mm, and spondylolisthesis grade 2 and 3, admitted to Sanjay Gandhi Institute of Trauma and Orthopedics from June 2019 to February 2020 were considered for the study. Inclusion criteria of study were spinal canal diameter less than 9 mm, spondylolisthesis grade 2 and 3, spinal canal stenosis with severe neurological claudication, age less than 70 years, patient willing for open and minimal invasive TLIF surgery and giving informed consent for the same. Exclusion criteria were traumatic or pathological vertebral fracture, multiple level involvement, grade 4 spondylolisthesis, severe medical comorbidities contraindicating surgery, and age more than 70 years. Total of 30 patients fulfilling the criteria were considered for the study. Patients were divided into two groups based on surgeon choice, which included 15 patients who were managed by open TLIF and 15 patients who underwent minimal invasive TLIF. These are the images, intraoperative images. First image shows the position of the patient as prone position on the Wilson frame. Second image shows open TLIF procedure. And third and fourth images are the intraoperative images of minimal invasive TLIF procedure. This is a CM image, intraoperative CM image of the same. And in minimal invasive TLIF, decompression was done with the help of microscope as shown in the image. These are the follow-up X-rays which were taken for immediate post-operative, 3 months, 6 months, and 1 year. Patients were assessed with VAS score, ODI score, Cobb's angle, and Bidwell fusion index. Intraoperative blood loss, duration of surgery, length of hospital stay were also assessed. Patients were followed up with post-operatively for functional and radiological assessment at 3 months, 6 months, and 12 months. These are our results. Both minimal invasive and open TLIF, majority of the patients were female patients. And in both open and minimal invasive TLIF, majority of the patients were in the age group of 50 and 60 years, 50 to 60 years. Postoperatively, the VAS score was less compared to minimal invasive TLIF patients. VAS score was less compared to open TLIF patients in both at post-op 3 months, 6 months, and 1 year. ODI score was also less for minimal invasive TLIF compared to open TLIF, indicating lesser morbidity in case of minimal invasive TLIF. Blood loss was also less in minimal invasive TLIF compared to open TLIF, as shown in the graph. And number of hospital stay was less in case of minimal invasive TLIF and open TLIF in our patients. But duration of surgery was more in case of minimal invasive TLIF compared to open TLIF in our study. Coming to discussion, Hams et al. First used TLIF in 1980s, and procedure had an added advantage over PLIF as it allows for unilateral exposure, sufficient disc space exposure, and resection of single facet joint, decreased neural retraction, and potential neurological injury. The TLIF procedure is a unilateral approach which prevents resection of the contralateral structures and preserves integrity of posterior column through minimizing lamina, facet, and pars resections. The main criticism of convention open TLIF were that because of extensive exposure of the vertebral column required for associated denervation of the paravertebral musculature, which lead to the morbidity of the patients. Police et al. First described this the novel technique of minimal invasive TLIF using specialized tubular retractors under the radical guidance via muscle splitting approach. Because of the limited incision length and localized splitting of the paraspinal muscles, the novel technique had reduced breast loss, minimizes the soft tissue damage and reduced recovery time, and reduced postoperative pain and decreased length of hospital stay. In our study, the minimal invasive TLIF had a lower VAS scores compared to the open TLIF, and ODI scores were also less, indicating the lesser morbidity in our study. Coming to conclusion, the minimal invasive TLIF provides a safe option for lumbar fusion, and the technique is comparable to open TLIF with similar operative time, equivalent to clinical and radiological outcomes, and comparable complication rates. But in addition, the minimal invasive TLIF to significant advantages over the open TLIF patients in terms of perioperative outcomes like lesser blood loss, pain, and earlier discharge from the hospital. Thank you.
This was a minimally invasive or open? This was minimally invasive or open?
This is minimal invasive.
And how was the cage applied with minimal invasive?
Sir, cage was dissection was done using microscope, sir, and cage was applied between the two percutaneous screws, making a separate incision.
Thing is, have you assessed the facet joints there? Because your topic is degenerative. This thing. How did you assess the facet joints?
Sir, MRI was done for the patient's preoperative.
No, endoscope, intraoperative. Because how did you select this minimal? You're going to do minimally or open? What was the criteria for that?
So we didn't have any criteria, sir. Based on surgeon's choice, it was selected.
No, in your inclusion criteria, you included almost all the conditions of the spine, right? So, but your topic heading says that degenerative spine disease. So it doesn't match.
The topic doesn't correlate with what you're taking.
Either you could have told operative time compared to open technique or functional outcome compared to open technique versus closed technique. But your topic says it is degenerative spine. So how can you consider or compare a minimally invasive procedure done for spondylolisthesis with degenerative disc disease? You understand? You got my point. So it's just the inclusion criteria has to be very specific when you are comparing two procedures, whether it with respect to a disease process or whether it's the implant system which you use or the technique you use. So it's not localized to a technique. You've generalized a degenerative spine condition and included almost all the conditions there.
Here, basically, here you have to remove the facet, at least half of the facets. Otherwise, you will not be giving relief to the patient. Pain relief will not be there. Your VAS score will be very bad. because it is a degenerative
Yes,
this thing.
spinal canal stenosis and disease.
Thank you, Vijay. Next presenter is Dr. Rajendra. Topic is to evaluate the functional outcome of management of posterior column of acetabular fractures by open reduction and internal fixation.
Good morning, sir. My topic is functional outcome in surgical management of posterior column or posterior wall of acetabular fracture by open reduction and internal fixation. Myself is Dr. Rajendra. I did my topic under the guidance of Ram Subba Reddy, sir. Acetabular fractures remains one of the most difficult orthopedic injuries to treat successfully, and one of the major advances in orthopedic traumatology is to treat the acetabular fractures. Until recently, all the acetabular fractures were treated primarily by the closed methods, and these conservative methods resulted in inability to restore the joint congruity, thereby causing the osteoarthritis and increased morbidity in case of patients. And the mode of injury is 80% of a patient of acetabular fractures results from the high energy trauma like RTA, and 10% of a patient with fall from height. This occurs mainly in the young and active individuals due to high energy trauma. And the posterior wall fracture with or without the dislocation is the most common type of acetabular fractures. Recently, it has become obvious the accurate reduction, anatomical reduction of the fracture is an important factor in achieving the satisfactory outcome. So the open reduction internal fixation is a better method than the closed method. The most common used implant is in case of a posterior column of acetabular fracture is reconstruction plate with plate and screws. And the operative management is usually offers a best chance of preserving a long-term joint function and early mobilization. My aim of study is to evaluate the functional outcome and the complication in the management of a posterior column or a posterior wall acetabular fracture by open reduction and internal fixation. This is a prospective study comprising of 20 patients. Study period from the November 2018 to September 2020. The place of study is Sanjay Gandhi Institute of Trauma and Orthopedics. Inclusion criteria: patient age more than 18 years of either of sex, and the patient presenting with posterior column or posterior wall fracture of acetabular. And exclusion criteria: patient with a pathological fractures and history of previous hip surgery, patient medical unfit for surgery, and patient with congenital anomalies or abnormal pelvis, poliomyelitis or neurological disorders, and patient not willing for surgery. The classification based on Judet and Little classification. In my study, there are among the 20 patients, 15 was posterior wall, and 5 patients presented with a posterior column fractures. Under the spinal anesthesia, patient made a lateral position. Under the Kocher-Langenbeck approach, open reduction internal fixation was done. That is the intro of fracture. First picture shows a incision. Second is a fracture of acetabular wall. And the fourth picture is a postoperative X-ray. These patients treated with open reduction internal fixation were treated with intravenous antibiotics preoperatively and postoperatively, and physiotherapy started from the day one. And the patient was followed up for interval of 6 weeks, 3 months, and 6 months, and 1 year, and evaluated with the functional outcome with Harris hip score and short form 36 score. And the postoperative management is to maximize the goals of the postoperative management is to maximize the functional status of the patient, so as to early return to the function and reduce the morbidity, and early detection of and appropriate management of complications. Mobilization protocols: day 1 started with the static quadriceps, day 2 with the continuous passive motion, and day 3 with dynamic static quadriceps and gait training. And the limitation of weight bearing continued for 8 to 12 weeks postoperatively. And observation and results: demographic data of 20 cases, 18 cases were male and 2 female, and mean age was 33.6 plus or minus 12.87. ranging from 19 years to 65 years, and the mode of injury was RTA majorly, and then fall from height. And side is right side, and mean weight bearing time was 11 weeks. And associated injuries, one case presented with a left both bone leg fracture, and another patient with a right distal and radius fracture. And complications in my study, one patient presented with a superficial surgical site infection, and one more is with post-operative foot drop. That superficial surgical site infection treated with intravenous antibiotic, and wound healed with secondary intention, and one foot drop post-operatively treated with a foot drop splint, and recovery occurred after 6 months. And the functional outcome, distribution of cases based on a functional outcome with Harris-Hip score. And I had an excellent study in case of 40%, and good in 35%, and fair in 20%, and poor in 5%. This is a comparison of mean Harris-Hip score between the different intervals: 6 weeks, 3 months, 6 months, 1 year. It is increased from 70 to 85.58, and it is comparable with the standard studies. This is a comparison of a short form 36 score. It was an increasing trend. Initially, it was 39.1, and it is increased at a final follow-up of 47.3, and it was incomparable with the standard studies. My conclusion is the management of these fractures become handy with the good reaction fracture of the fracture and instrumentation resulting in the good outcome with the surgical complication less, and good to excellent results in achieved in 75% of total cases, and fair in 20% of patients, which is attributed to the poor bone quality and postoperative infections. So we conclude that management of posterior wall or posterior column of acetabular fractures is best achieved by the means of surgical approach, that is open reduction internal fixation with plate and screws. This is an illustration. This is a pre-op X-ray, that is an immediate post-op X-ray. This is a range of motion at the final follow-up with a good range of motion. This is a 30 years of patient with presenting with a posterior wall fracture with a dislocation, posterior dislocation, operated with open reduction internal fixation after reduction. This is a final follow-up range of motion.
So pure posterior column fractures you have
Yes,
taken. When did you mobilize the patient weight bearing?
So weight bearing, it was of 12 weeks, sir.
Any CT was done?
Sir?
Any CT was done?
Pre-operative CT was done, and the fracture pattern was confirmed, sir.
And interruptively, CM was used, or image was used, or image was not used?
Image was used, sir.
There's nothing mentioned there.
So fracture reduction was confirmed under the CM images, sir. Intraoperatively.
You had to do a trochanteric flip osteotomy?
No, sir.
No?
No, sir. Thank you, sir.
Thank you, Rajendra. Next presenter is Dr. G. Krishna Naresh Gaud. The topic is Transcuff Portal a safe portal? A prospective study about healing of transcuff portal with ultrasound guidance.
Presentation, they have loaded the other one. No, they have loaded the other one. That is a case report. Yes. Thank you. Respected teachers, seniors and dear colleagues, myself, Dr. G. Krishna Naresh Gaud. I am presenting Is Transcuff Portal a Safe Portal? A prospective study on healing of transcuff portal using ultrasound guidance. This study has been done under the guidance of Dr. Ayyappan V. Nair at Manipal Hospitals, Whitefield, Bangalore. Shoulder comprises of rotator cuff muscles, which are a group of muscles including supraspinatus, deltoid, infraspinatus, subscapularis, and teres minor, out of which supraspinatus and deltoid are mostly helpful for abduction of the shoulder. There are many portals are present for the treatment of slap lesions or Bankart lesions, like the standard anterior portal, posterior portal, anterolateral and posterolateral portals, other accessory portals like transacromial portal and Nevazier portals. Now coming to what is a transcuff portal. Transcuff portal is a portal which is made just lateral to the lateral end of acromion in the midline in the shoulder. What are the advantages of the transcuff portal? Transcuff portal is helpful in placing of anchors at optimal position in slap and Bankart lesions. It is also helpful for as a viewing portal in posterolabral pathologies. Nowadays, it has become a new normal for using this portal. This transcuff portal has been described as a technical note by John G. Kostras et al. In 2006 first. After that, in 2008, there is a study where they have described that the amateur surgeons who are in the early stages of arthroscopy, by using transcuff portal, they made the portal through the tendinous portion of the supraspinatus, leading to rotator cuff tears rather than treating the pathologies. So our aim is to see whether this portals is healing or not, or whether the placement is correct or not. The present study has been conducted at Manipal Hospitals, Whitefield, between 2018 to 2020. 22 patients diagnosed as Bankart or slap lesions have been included in the study. Normal side along with the abnormal side has been evaluated clinically before the surgery. Radiological and other investigations has also been done. Functional outcome has been seen before. And transcuff portal is used in all the patients for placement of anchors in the study. The minimum follow-up of 6 months with a maximum follow-up of 2 years. All the follow-up visits we have evaluated at 1 to 6 months and 1 year, 2 years of the study. During the visits, we have made an ultrasound scanning for each visit, and we have quantified the healing of the portal by using ultrasound. Basing on the quantification of ultrasound, we put forward a classification which can be classified basing on the thickness of healing of supraspinatus tendon. We have divided into 3 grades. Grade 1, which is complete tear and not healed from the bursal side, or whether the healing is less than 50% from the bursal side. Grade 2 is the healing is present, but it is less than 50% from the bursal side. Grade 3 is where the healing is greater than 50% of the bursal side, or whether it is completely healed. This helps us in treating the problems of the patient while they come for follow-up. And clinical, radiological, and functional examinations are also done by using ASCS, Oxford, and constant functional scorings. Out of the 22 patients, 4 are male and 18 are female. 3 patients lost follow-up, leaving 19 patients for the study with a mean age of 52. And basing on the USG grading, 17 patients of the 19 patients are grade 3, and only 2 patients are grade 2, and we don't have any grade 1 patients in our study. This ultrasound, we can see on the left side, there is a more than almost around 50% of the thickness of supraspinatus needs to be healed. So we classified it as grade 2, whereas in the opposite side, there is almost complete healing and less than 50% of the healing. And when you compare to the opposite side, it is almost the same. So we have changed it, we have graded it as grade 3. The functional scoring using ASCS score, constant score, and Oxford score, all are comparable and comparable to the literature, which increased after the study. Coming to the, sorry. Functional scoring using ASCS score, constant score, and Oxford score, all are comparable and comparable to the literature, which increased in post-operative period. Coming to the discussion, See, only study which used for healing of the portal seeing was done by John Wu et al. In 2008. They used a CT arthrogram. They saw that there is a leakage or not by using the arthrogram. If there is a leakage, they considered it as a negative, or if there is no leakage, they considered it as positive. We, in our study, tried to quantify the amount of healing. This helps us in the planning the treatment of the and other functional scoring also. Our functional scoring, we have achieved 85 with a maximum score of 93. Other study which compared to the other studies, Milchi et al. In 2016 was the largest study in where they use a Transcuff portal for using the functional score. In that, they have mentioned the average score of 91.7 after using the Transcuff portal. But the only difference in these two patients, in these two studies, is that they are all contact sport athletes, where in our patients, where there are normal patients or any recreational athletes. Advantages of the study are advantages. They use ultrasound, which is a non-invasive procedure and is safe and easily tolerated by the patient, relatively cheap. We have also some limitations that, like, we don't have any comparative group for evaluation. Further, more studies are required. An inter-observer variation in ultrasound, we tried to remove by using a radiologist, by making radiologist blind for the study. Finally, I conclude that Transcuff portal is a safe portal for repair of slap lesions and Bankart repair, and gives proper angle for the placement of anchors. The functional outcome, when compared with other routine portals like anterior superior and posterior superior portals, as comparable and good satisfaction and return to work. USG scoring helps in confirmation as well as treatment planning after the study. Thank you. Thank you. Sir, actually, what normally while doing Bankarts, we try to put the anchors to the posterior superior portal or the anterior superior portal. Yes, sir. And sir, yes, sir. Yes, sir.
Can you hear me now?
Yes, sir.
Yeah. So your title and your conclusion doesn't match.
Sir, our study, what we try to achieve, we try to see is, sir, normally, as I told earlier, while doing in the early amateur surgeons or first who starting arthroscopy, when they try to use the Transcuff portal, they are putting through the tendinous portion, sir.
Yeah, all those procedural things we have
Yes, sir.
understood, you're told,
Yes, sir.
and you've detailedly mentioned
Yes, sir.
about it. Our question is your conclusion and your topic heading, whatever you have submitted and projected there, they don't match.
Sir, sir, it is a safe portal, I can say, because we try to put the cuff portal and we are just seeing.
So it should have been our results with respect to Transcuff portal, our results. Right. And then you told that we have done a classification. So is it a reference classification or it's an indigenous classification you people have come across?
Sir, there is no classification for per se for healing.
So
of
before we put on a classification, was there any inter-observer? You told that
Yes,
the
sir.
radiologists
Yes,
were
sir.
blinded.
Yes,
so was the sensitivity and specificity calculated before the classification was taken into consideration?
Sir, for what we did was, sir, the radiologist, what I say, was blind for the study. For
Thank
doing,
you.
Yes, sir.
Yeah, I have got a question for you here.
Sir.
So you said you're doing this for Bankarts and slap tears only.
Right, sir.
But your mean age is 52, 40 and 58.
Yes, sir.
Did you assess the condition of the cuff before doing the Transcuff portal?
Yes, sir.
In an MRI?
Sir, before going for the surgery only, we examined clinically both the shoulders as well as radiologically the affected shoulder by using MRI and as well as ultrasound for seeing the cuff, sir.
But you have not included in the exclusion criteria, you have not mentioned that.
Sir.
I got to mention that. Yeah.
Thank you, sir.
Doctor, you have
next,
mentioned a very good study.
Thank you, sir.
What do you mean by a Transcuff portal The normal portal, viewing portal is not a transcuff portal.
Sir, normally what we use is a lateral portal, whereas a transcuff portal is more
No.
medial.
What I'm asking is when you done an ultrasound study, there's a posterior portal for viewing also.
Yes, sir.
Okay, that is standard portal for most of the surgeons.
sir.
If that heals well, this also should heal well. Okay, first point. Second point, very good study, because something you try to do, something new, and try to find out how the healing happens after the cuffs there. Okay, now the latest things are curved anchors have come, curved sutures have come, suture passers have come.
Yes, sir.
Okay, and transcuff, when you say transcuff, you need to define the tent from the bone GT to the how far are you from the GT to the cuff? Okay, so if you define that one, then you take an MRI, then it gives a fantastic results.
Right.
Okay, so if you give an MRI, then the inter-radiologist opinion will be eliminated. Okay, and portal, when you are checking, anyhow, checking the ultrasound with the cuff portal, supraspinatus, check for the infraspinatus also, no?
Yes,
it gives you more information.
Right, sir.
Yeah.
Thank you, sir.
Thank you.
Thank you.
The presenters, please stick to your time.
Yes. Thank you, Dr. Krishna. Next is Dr. Vikas. Yeah. The presentation is arthroscopic latter J with remplissage is an effective procedure in converting off-track lesions to on-track lesions.
Thank you all. This is sir. Thank you all. I am Dr. Vikas, Dr. Vikas Kuntod, presenting on arthroscopy latter jet with remplissage is an effective procedure in converting off-track lesion to on-track lesion. This study conducted in Manipal Hospital, Whitefield, under the guidance of Dr. Ayappan V. Nair. Latter jet procedure is done for the cases of recurrent shoulder instability with the bone defects of glenoid bone loss, as well as instability in high-level athletics. Latter jet, as we know, produces triple effect on shoulder. Contribution of lateral jet is resurfacing glenoid. Lateral jet procedure is preferred by many surgeons for treating glenoid up to glenoid loss up to 35%. During lateral jet, the coracoid width can increase up to 31 to 35% in various studies. Failure of lateral jet with possible causes. Failure of lateral jet is about 3%, with frank dislocation about 13%, with residual instability. Possible causes: remplissage not being done, non-healing of graft. Concept of off-track, on-track originally concept by Yamamoto in 2017. Clearly explain the importance of risk of engagement of Hill-Sachs. Our hypothesis: glenoid track may remain off track even after doing lateral jet, probably due to large Hill-Sachs, which is not contained by lateral jet. Hence, remplissage should be done as an additional procedure along with lateral jet. Our inclusion criteria: patient with multiple dislocation with bone loss greater than 15%, failed Bankart repair. Then Hill-Sachs engaging and non-engaging lesion before and after lateral jet. This shows how even after lateral jet, some patient may remain off track. So remplissage is an effective procedure in converting off track to on track. Our aims of study: pre-op and post-op glenoid diameter by base fish circle method, and Hill-Sachs measurement on CT, healing of the coracoid process on CT, position of coracoid clockwise from distance from the glenoid surface, and pre-op and post-op glenoid track on CT. Methodology: 15 patients we selected for the study. All are operated by single surgeon. All undergot arthroscopy lateral jet with remplissage with labral attachment. 14 patients with operated with Mitic screw system, and 1 patient with arthritic screwless fiber tape system. Pre-op assessment done on CT and MRI. CT done at 3 months post-op. Functional outcome: all patients done at 3 and 6 months. Demography: 15 patients, male is to female ratio 12:3. 5 patients with previous failed Bankart repair. 10 patients with 15 to 30% of bone loss. 3 patients were professional athletes. All patients were off-track pre-op. Calculation of glenoid track is done on the basis of base fish circle method. This is normal glenoid diameter. This is glenoid of a affected track. This is affected glenoid diameter. This is coracoid width increase. Then also we did assessment of osteolysis of graft around the screw and the angle of screw to glenoid. Then also we see coracoid position, whether it is medial to the glenoid, whether it is lateral to the glenoid, or it is flushing to the glenoid. Then results of our study, glenoid track. Post-oply, we see whether it is off track. Seen 5 patients remain off track. On track were 7, and borderline on track were 3. What is borderline? Borderline is the difference between glenoid and hill sac difference is 5 mm. We can consider it as a borderline. Then glenoid diameter is pre-op range 20 to 27, post-op range 30 to 36, bone loss 21%. Coracoid width, coracoid position was found to be medial 5 mm, lateral 2 mm, flushing 8. Osteolysis is found mainly on upper screw 10 and 2, and 3 is none. Then shoulder stability score was measured. Pre-op was 20-25, post-op at 3 months 40 to 45, post-op at 6 months is found to be 50 to 58. Angle of screw insertion average is found to be 18 to 23, upper screw, lower screw 20 to 28. Range of movement at all follow-up for 3 and 6 months, patient got full range of movements, except 9 patient got 10 degree of external rotation deficit, 1 patient with internal rotation deficit. This is arthroscopic screwless lateral jet procedure done with screwless lateral jet system with arthric system. This is a capsular dissection, remplissage being done, then capsular dissection, then glenoid and coracoid passed, then looping is done on the procedure. It's a screwless arthric system, then tightening of the loop with the tension tightener system, then throwing of the knots, and finally we see the tightening of the fiber tape on the graft, coracoid graft. And this is checking the graft position and capsular reattachment done. Then this is a case study, a case of a 30-year-old male complaint of recurrent shoulder dislocation for which underwent 2 times Bankart repair outside, came to us. Recreational sports person, instability severity index score was 5. Pre-op was 20% bone loss, off-track lesion. Hill sac's lesion was greater than on-track, so off-track lesion. Then post-op found to be clock position 2 to 5, coracoid, and then in relation to glenoid surface medial to 4 mm to the glenoid, position of screw found to be divergent, healing of the graft complete, bridging is seen. Then osteolysis of coracoid is seen around upper screw at upper angle 18, lower angle is 21. This is a range of movement of the patient. We found full range of movement at the follow-up of 3 and 6 months. Only external rotation deficit of 10 degree. Then in discussion, the Oxford shoulder score of patient post-op ranges from 45 to 55. 5 patients remain off track after lateral jet, but remplissage procedure along with prevents engagement. None of our patients got subject to apprehension at 3 and 6 months. In also in our study, borderline tracking term includes, which is 5 mm to on track. The lateral jet procedure is excellent procedure in shoulder instability, considering 3 to 13% of failure rate of lateral jet. It is advised to do remplissage in patient with hill sacks. We suggest it is always to do combine lateral jet with remplissage for optimum results. Thank you all.
Pepe, you want to tell that, augmenting with remplissage in an hill sac's lesion associated or recurrent dislocation gives you a better on track rather than an off track, which is provided by a lateral jet, exclusively lateral jet.
Because sir, lateral jet has also failure rate, and most of the failure rate has found that hill sacks is not considered. So that is the main reason. So we suggest that it will be a good effective if you do along with remplissage.
So what is the disadvantage of doing an extra remplissage along with latachet?
A disadvantage is some patient found sir extra rotation deficient.
So
but
mobility at the cost of
mobility.
stability.
But mobility as such, sir, if we found good physiotherapy, good therapies, then they will rehab well, sir. If they follow good, then the rehab will good. It's not like that they will have some patient which they do not follow, they will have.
Okay.
Okay, thank you, sir.
Thank you, Dr. Vikas. Next presenter is Dr. Chandrasekhar. Accuracy of radiographic assessment of vestibular component antiversion and inclination after THR in CT-based measurements.
Good morning, sir. I'm Dr. Chandrasekhar, and my today's topic is accuracy of radiographic assessment of acetabular component antiversion and inclination after total hip arthroplasty in comparison to CT-based measurement. Coming to the anatomy of the hip. Hip joint is one of the largest joint of the body. It is a ball and socket type of the joint. The socket is formed by the acetabulum and the ball is formed by the femoral head. These bone surfaces of the ball and socket are covered with the articular cartilage that helps in cushioning the ends of the bones and enables them to move easily. A thin tissue called synovial membrane surrounds the hip joint that helps in secreting the synovial fluid that lubricates the cartilage and eliminates the friction in the hip. Various ligaments and capsule provide stability to the joint. Total hip arthroplasty is a surgical procedure where diseased hip joint is replaced with the prosthetic components to relieve the pain and restore the biomechanics. Hip replacement components. Acetabular components mainly cup usually made up of titanium, stainless steel, or chromium alloy. Liner made up of mainly plastic, metal, or ceramic. Femoral component consists of head, neck, and stem. Coming to the acetabular position, malposition of the acetabular component after total hip arthroplasty is related to the dislocation of the prosthetic head, increase in the polyethylene wear, and limited range of motion. The orientation of the acetabular component comprises mainly inclination and anteversion. Although the inclination of acetabular component can be measured on the plane radiograph, calculation of anteversion is difficult. There are several radiological methods for measuring anteversion of the acetabular component, and a single standardized method has not been established for anteversion. Coming to the definition, the radiographic inclination is defined as the angle between the transverse plane and the acetabular axis, which is projected on the coronal plane. The definition of anteversion is angle between the acetabular axis and the coronal plane. This is my post-op X-rays to measure the inclination. A transverse plane connecting the two ischial tuberosities and a line connecting outer lip and the inner lip of acetabular cup gives the inclination. That is same in CT-based measurements, transverse plane and line connecting the outer lip and inner lip of the acetabular cup. This is for calculating the anteversion. Axial section of the CT is taken, line joining the center of the hip joints, and a perpendicular line taken to this line, and the third line connecting the anterior and posterior most acetabular lip gives the version angle in CT. That is the calculating a version on lateral radiograph. A longitudinal axis along the table and a line perpendicular to this longitudinal axis, and the third line connecting the anterior most and posterior most point on the cup gives the version angle on the lateral radiograph. The objectives of study is to assess the accuracy of measurement of acetabular cup antiversion and inclination after total hip arthroplasty using plain radiograph versus computer CT based measurement. To determine if plain radiograph is reliable method for determining acetabular cup version and inclination. Inclusion criteria: patient aged more than 30 years and less than 80 years, mainly osteoarthritis of hip. Exclusion criteria: patients with protrusio acetabular, dysplastic hip, and acetabular fractures, and patients with active infection in the body or septic arthritis or neuropathic joints. Optimal cup orientation is of substantial importance for long-term function and low complication rate after hip arthroplasty. Improper cup positioning always leads to a limited range of motion, accelerated wear of the components, and early dislocation. Antiversion and inclination are two primary indicators of the cup orientation in total hip arthroplasty. The results were the mean radiographic values measured on plain radiograph were 17.9 degree with standard deviation of 8.7 degree for version, and on plain radiograph 39.4 degree with standard deviation of 5.5 degree for inclination. In CT based measurements, the mean value 17.4 degree with standard deviation of 7.9 degree for version and 37 degree with standard deviation of 5.9 degree for inclination. So my conclusion: accuracy of measurement of acetabular cup version and inclination of total hip arthroplasty using plain radiograph is almost equal with the CT based measurement. So we can use plain radiograph for determining cup version and inclination. As plain radiograph is cost effective, measurement of cup version and inclination on plain radiograph is reliable and accurate compared with the CT based measurements.
How many cases? Yeah.
Sir, 30 samples followed up.
Okay, thank you.
Thank you, Dr. Chandrasekhar. Next presenter is Dr. Surya. Can smartphones be used for angle measurement on arthritic knees? A comparative study with manual method.
So good morning, everyone. So I'll be speaking about the topic: can smartphones be used for angle measurements in arthritic knees? That is a comparative study between the yeah, I'll be speaking about this topic: can smartphones be used for angle measurements in arthritic knees? That is a comparative study between the smartphones and the manual methods. Myself, Dr. Surya, and the study was done under the guidance of Dr. H.P. Shivkumar and Ravi Shriyan. So we are living in a modern era where big size computers have become small desktops, which later changed to mini laptops, and now everyone is using a smartphone, which is both a mini computer and a phone. Smartphones have pretty much changed our lifestyle in doing every work, right from order and getting anything to even its usage in medical fields. So one such application with accelerometers can be used in our orthopedic field for measuring varus or valgus angles in arthritic knees. So coming to the introduction. So measurement. Yes, that is it. Yes. So coming to the introduction, the measurement of the varus or valgus angles in arthritic knees has been widely accepted to analyze the extent of deformities and can be used as an indicator of the degree of correction obtained following a corrective surgery. So measurements has traditionally been manual using a pencil, scale, protractor, goniometer, or radiographs. So smartphones have changed the way we live in every field of life. Use of apps in smartphones with accelerometers aids to measure the angle quickly. So this study analyzes the accuracy and efficiency of the applications with accelerometers in smartphones to measure varus or valgus knee angles. So the methods used, we analyzed varus or valgus angles in 25 subjects or 25 arthritic knees. The ethical approval was taken from the committee. So coming to the radiographs, in our study, a full hip to ankle X-rays or a scanogram was used and was obtained using a dedicated 51 by 14 inch graduated grid cassette, which included the full limb of tall subjects. So the subject stood without footwear, leg in neutral position with patella facing forwards with the X-ray beam centered at the knee at a distance of 8 feet. So all radiographs were obtained with the same technique for each subject. So angles from the radiographs were measured as described below using a standard plastic 30 centimeter goniometer and application with an accelerometer. That is, we used a multiclinometer app. It was by the physics software and recorded in degrees, that is plus or minus 180. So angles greater than 180 represent a valgus and angles lesser than 180 a varus alignment. So mechanical alignment was measured using the hip to ankle radiographs by measuring the angle in degrees, subtended by one line connecting the center of the femoral head with the middle of the knee and the other line connecting the middle of the surface of the talus with the middle of the knee. So this becomes a mechanical axis. So time taken to measure using both the techniques was noted by other observers. Another 2 observers then independently measured the angle using their smartphones to assess the inter-observer variability, and data was tabulated and analyzed. So here is a first example where the line was drawn from the center of the hip to the middle of the center of the knee, that or the intercondylar notch, and another line from the center of the knee to the surface, middle of the surface of the talus. And then the angle subtended between that is measured using a goniometer here. And this is using the app where we place the phone over the line drawn from the center of the knee to the center of the hip to the center of the knee. Either it's placed parallel or over the line and the angle is measured. So this is an angle measured directly in the packs. So this is another example where we've used a goniometer and the angle is measured. And here the smartphone is used. And this is another example. So coming to the results. So knee angles of 25 patients with mean age of 61.5 years were analyzed for varus or valgus angles separately. So the mean angle of all measured X-rays was 7.8 degrees in manual set and 7.9 degrees in smartphone set. The mean time consumed was 13.5 seconds for the smartphone set, significantly shorter than that of the manual set, which was 36.2 seconds. So 95% confidence intervals for the inter-observer variability using smartphones were average mean plus or minus 1.5 degree. So the parameters, the mean age was 61.5 years. There were 13 right knees and 12 left knees which were assessed. And using the manual methods, it was 7.9 degrees, and using the inclinometer, it was 8.1. And in the right knee, and in left knee, it was 7.7 degrees in using manual methods and 7.6 using the inclinometer. And the mean angle was 7.8 to 7.9 using manual and inclinometer. And the time taken was very significant with 36.2 seconds in using manual and 13.5 seconds in using the inclinometer. So the maximum number of patients were found between the age groups of 60 to 70 years. And this is the graph showing the angle measured in each of the cases. And this is the time taken by the manual methods and the inclinometer. So coming to the discussion, knee angle measurements using the smartphone was comparable to the manual methods in our study, with significant time difference between the methods, indicating the simplicity of the use of applications in our daily use and the minimal observer variability. Smartphones indeed can replace the manual methods and can be a reliable tool in hands of arthroplasty surgeons. Thank you. We cannot carry. We can use a smartphone as a substitute instead of a goniometer in few of these cases. We can't actually replace the goniometer with a smartphone, but we can use it as a substitute when the goniometer is not available.
Why goniometer is not available?
At all the times, it is difficult for a surgeon to carry a goniometer, and the smartphone is always available with us. So,
is accepted by the Orthopedic Society?
No, sir. This is just a comparative study. We cannot replace it. It's just a substitute. And yes, sir.
See, with this presentation, what is your interference?
The advantages were the time taken was significantly different, and the inter-observer, the angle measured using the smartphone and the manual methods was more or less it was very accurate. So we can use it instead of a goniometer in few.
How much is the accuracy?
It's 1.5 degrees. The mean plus or minus 1.5.
In the percentage?
Percentage was not.
Percentage of accuracy.
It was 95% accuracy.
95% accuracy?
Yes.
A smartphone.
Yes, sir.
And goniometer?
Compared to the goniometer, it was 95% accurate. The user smartphones was 95% accurate.
Oh. When you say
This is only useful in the radiographs. We can't use a goniometer while calculating the angles, fixed flexion deformities. It's only in the radiograph.
What is your carry home message to the audience?
When the goniometer is not available, like especially in these cases where you have to measure the angles for total knee replacements.
So don't advise that. Don't advise that. Goniometer is compulsory for every postgraduate students, even orthopedic surgeons, to carry to measure the gonio angle on the X-ray and clinically also. So don't recommend that you should carry a smartphone and measure it. The basic requirement like a stethoscope. Okay, for orthopedic surgeon.
Yes.
Yeah, I think so. The message has been clearly given that, it's not a replacement, and we can't advise regarding that because it's still not proved. Probably one of the reason why, this paper cannot be validated and a message conveyed is your sample size is just 25. Okay. And it has to be a multicentric study. There should be inter-observer error calculated. A lot of things which needs to be put on this paper before we can really watch on it and tell that, okay, you don't carry a goniometer. So that's a wrong message. Yeah. It's probably a technique to aid your traditional method. That could have been a better topic, I think.
And the time difference is only around 15 to 20 seconds.
Yes. Thanks.
Thank you, Dr. Surya. So we have come to the end of the free paper presentation. So we will have a AGM meeting now. Only BOS members are requested to stay back in the room, which will start in about 5 minutes. Non-BOS members